the challenges. Just a quick case, 87-year-old. Really like you to leave this session, at least from my talk, and thinking very differently from the standpoint of how you treat femoral popliteal disease. The old school of, okay, we're going to just lay a stent, or just I'm going to do drug-coated balloon. Let's just go past that and start thinking of segmentalized approach. Some areas you're going to put DCB, some areas you may put Supera, some areas you may combine the two, some areas you may put drug-eluting stents. So in one segment, in one artery, you may end up at the end of the case finishing with 3-4 different devices for the optimal best therapy. So this gentleman, we brought him in, as you can see, as severe CLI, has a popliteal occlusion, has a 3-vessel runoff. And the point of this, I'm going to skip some of this. We did some complex work, retrograde, to cross the lesion. The bottom line is that we crossed it, now we want to treat it. What should we do? Are we going to take the stent approach, or are we going to take the non-stent approach? By the way, I wrote this, but I don't agree with it anymore. So, because I think we have to be even more dynamic than that. There is no reason to be so dichotomous. I think we have to go with a flow kind of a thing, rather than saying, no, I'm not going to use stent. If you have to use a stent, use a stent. So being mindful that you have the options, I think what's important is that you have all these options at the bottom. And this is in your toolkit, in addition to some of the other advances, things that we're seeing coming out, like the shockwave, lithotripsy, and other things that are coming. So having the toolbox and then applying it as necessary, rather than making the decision right off the bat. So again, in that case, we had to do all these complex things. So when you have to do these things to cross the lesion, you're already thinking, okay, I'm subintimal, I have a dissection. I'm probably not going to get away with not putting a stent in this situation. So there's no way I can make that decision before doing all this, because I don't know how the thing is going to come out. So in this situation, I decided to use a Supera. Now, should I have used DCB plus Supera? Should I just use Supera? Is the DES would have been as good in this situation? Well, there is some calcification in this artery. It is behind the knee. So you have to think of these things in regards to your selection of your device. What anatomy it is, where is the location, what is the calcification, and what are the things that are going to affect this therapy. In this situation, because of the dissections, I knew that DCB alone was not going to work. It's behind the knee. I want to have radial force. I want something that's not going to fracture. But I think Supera is probably the best option for me in this situation. We know the data with the DES. I'm not going to belabor this. And we have 5-year data now. So we feel comfortable with these technologies. We have drug-eluting stents. We have drug-coated balloon, now 4-year data showing superiority. We have Supera now with 3-year data from Dr. Garcia's work, showing that excellent patency up to 3 years with wire interwoven stent. So has there been a paradigm shift? I really believe it has. I think that we are, at least I am, more in line with putting less stents. But I'm not afraid of putting a stent if I need to. I'm not going to compromise patency because I'm trying not to put a stent. Because the ultimate goal for me either is patency for claudication, and for CLI is wound healing and patency. I would say wound healing first. So, and that's the way I look at it. So I approach these cases with that mindset, but knowing that I have a lot of tools that I can use to try to get the lesion treated. The challenge is that sometimes people go to the extreme. So we do the paradigm shift, we talk about DCB, and then people say, you know what? Oh, it's just a TAS C dissection. Oh, it's a D. It's very subjective. You look at it, you say it's a D. I look at it, I say it's a C. Somebody else looks at it, say it's a E. Some people say, oh, I look at the flow in the profunda and the SFA. If one is slower than the other, then it's significant. These things are too subjective, right? We are dealing with patients. We are dealing with people's ability to walk and not have pain or heal their wounds. And we need to understand that DCB, while has really made a change in the way we practice, has limitations, as I have outlined here. And this is Dr. Thomas Zeller. I think you wrote this a few years ago, Thomas, maybe 6-7 years ago, where you said hope and or hype. I think it's been more hope, I hope, in the way that we have treated these patients, no pun intended. And lastly, I would say that, again, the point of subjectivity. There is a lot of subjectivity when it comes to dissection assessment. And I hope that we can evolve and be more objective like we have done in the coronary anatomy, where we are doing pressure gradients, we are addressing, you know, what is the residual stenosis. So this is a paper from coronaries showing the residual gradient beyond stents in the coronary bed. And these are all normal FFRs, right? They're all above 0.8. But if there is a gradient, the binary stenosis at 9 months was 44%. This is in the era of bare metal stents. If there was no gradient, it was 8%. So if a patient comes in with claudication and we're treating them, and now we're leaving the patient with significant dissection without subjective assessment, are we doing the right treatment for those patients? And we have the challenge, obviously, with the healthcare environment around us too. So we have to take that also into consideration. How do we manage this? We have good technology, we have good evidence, but we don't get paid for it. And how do you balance that in treating these patients and making sure that we have the best patency for our patients? So at the end, this is, I think, my last, or the one before last slide. I think that we should approach femoral popliteal disease in segments. And the way we should look at it is by plaque morphology. If it's heavy calcification, as Dr. Zeller said, well, you know you're going to probably end up with a wire interwoven kind of a device, or a combination of something that deals with calcium plus that type of a stent. We want to know the location. If it's osteal SFA, it's unlikely I'm going to use an interwoven wire because it's hard to deploy that stent in the ostium of the SFA. I may decide to go with something else. If it's either stenotic or occlusive, we know stenotic lesions, we have much more options in our armamentarium. They do much better with atherectomy because we are luminal versus occlusive. And then patient characteristics, you know, diabetic patients are more prone to have calcification, and we know that diabetic patients have poor runoff. So at the end, I think that in the future, at least in my practice already, I may enter a femoral popliteal lesion and end up coming out with 3-4 different devices that I've implanted in a femoral popliteal segment. Thank you very much.